So the goal in ovarian cancer surgery is one true goal. It's always R0, you call it R0, you call it CC0, you call it no visible residual disease. The absolute complete clearance is the single most powerful predictor of survival. Even in the era of multiple adjuvant therapies, multiple lines of PARP inhibitors and all, the only question is when to achieve it. So learning from the previous trials, which are the low effort legacy trials. Why I call them low effort trials? Because the upfront R0 resection rates in these trials, the population studied is very dismal. 20% and 19% upfront R0 resection rate is not an acceptable surgical outcome which we are aiming in this day and age. And the outcome reported verdict is NACT is non-inferior in these trials of EORTC and chorus, but it only proved that bad surgery is equated by, the outcomes are equated by a chemo. And coming to the newer trial, the TRUST trial, in which Sir depicted that it is near equal outcomes, but the thing to note in these TRUST trials is the R0 resection rates were much better in the primary cytoreductive surgery arms of around 70%. Here the surgical excellence is validated, and this trial, the centers were reported to be required to at least have a 50% baseline R0 resection rate to be eligible, and high volume hubs only, at least 36 cases per year was the cutoff they have taken. And the result was statistically significant PFS benefit from primary surgery, and there is also a clinically meaningful OS benefit from the primary surgery in this as well. These are the outcomes, and I agree that the OS endpoints were not met as per the statistical significance, but in PF-OSS dissociation, it is almost universal in all discussions in this day and age, given the overlap of clinical trials, adjuvant therapies, multiple options of treatment after initial failure. So OS being non-significant, we cannot disregard it as a zero result. And also the subgroup analysis in these trials pertaining to biomarkers like HRD, already the surgical trials, the number accrual and the numbers which are studied is too less. If you include a surgical subgroup analysis, the outcome analysis becomes even more skeptical. So the OS endpoint paradox is that multiple lines of secondary treatment can compromise that, and we may argue that this R0 rate is being 70% is not achievable. The rigorous surgical quality which is shown in the TRUST trial setting is not achievable in Indian scenario, but this is the reported R0 surgical rate in expert surgical centers in very our own country by ISPSM data, and this not generalizable to Indian centers is a claim to, it's a race to the bottom. You cannot, geography cannot dictate the surgical biology and the surgical effort which you should give to the patient. The solution is not to lower the standard of care. We have to refer to the expert centers where treatment is optimal and mandate which can be achieved better. So coming to the understanding about the PARP inhibitor scenario, R0 resection, it makes the maintenance work better. As Sir rightly mentioned before in the before talk, that the debulking surgery, suboptimal debulking surgery, maintenance outcomes are around half. The outcomes are half when compared to optimal cytoreduction. And surgical morbidity. The one argument which always comes out in terms of when we are looking across primary cytoreduction versus interval cytoreduction is primary cytoreduction has more morbidity. But when we look at the trial data, at least, while the relative risk numbers, they show 18% versus 12% split, the major morbidity, 94 out of 100 patients who underwent the treatment, they are absolutely fine without any major complications. And the clinical equivalence, there is no mortality difference in these patients, and there is zero impact, near zero impact on the long-term quality of life. So the point here is transient versus permanent morbidity. PDS is too morbid. Yes, it was too morbid, but we live in an era of ERAS and optimized multidisciplinary management in where the expertise of all our colleagues in managing these patients is increasing. So even when the surgery is prolonged, even when the blood loss is more, even when the initial management becomes difficult, but it is transient. Once the center gains experience and expertise, not just the surgeon. The center gains experience. This I have witnessed in my very own parent institute, where I have seen the CRS HIPEC journey over 5 years, grow over 5 years. There was a learning curve which we even published, that after 50 cases, the morbidity becomes acceptable, comes to acceptable levels, and the mortality also decreases. So the real morbidity where we should be looking is the early disease recurrences, which we see they are more morbid than a successful operation. Manageable morbidity is the keyword, is manageable morbidity. If the morbidity is manageable in your center, yes, primary cytoreductive surgery is the way to go. And the pseudo R0 illusion which post-NSCT cytoreduction gives us, you see, you tend to refer the patients for a neoadjuvant chemotherapy when you assume that the upper abdominal disease is more, the subdiaphragmatic disease is more, the critical areas like porta-hepatitis and root of mesentery are involved, and even all those cases, majority of the times, even post-NSCT, the biomarkers, they show the disease is responded, excellent response, imaging doesn't show any disease. When you put in a scope, when you open the abdomen, then you see a sheet-like fibrosis on the peritoneum. Whether it contains the disease or it doesn't contain the disease, it's a matter of debate, and many studies they show that there is a discordance about the cytological zero of the disease response at those sites. So, and also there comes the HIPEC conundrum. The trials OVHIPEC 1, every trial has shown only survival benefit in the interval setting. For me, this would represent again the molecular MOF mechanism. I would call ki you do a suboptimal cytoreduction in terms of microscopical disease remnant in the fibrous tissue planes and the fibrosis which you leave behind in the upper abdomen during a NSCT cytoreduction. It is taken care of by the HIPEC and all other adjuvant treatments. So if you do a proper cytoreduction, CC0, the true CC0, if you achieve, then you should be able to get the survival benefit in the long term. And OVHIPEC, you cannot use it as an argument for NSCT cytoreduction because that trial did not enroll primary cytoreductive surgery patients. So primary cytoreductive surgery at a base will be studied in outcomes when OVHIPEC 2 comes out, then we will know. And total parietal peritonectomy, this entire argument of total parietal peritonectomy was invented for, and it was studied almost entirely for the interval setting, because in primary cytoreductive surgery setting, the disease is where you see it, at least the macroscopic disease, at least the one which we can be removed, it is there. The selective parietal peritonectomy is true only in case of a primary cytoreductive surgery setting. In post-NSCT setting, initial you see a disease in over the abdomen, true invasive peritoneal disease, it never goes back without leaving a mark of fibrosis there. Whether you remove the fibrosis or just one more two slides. So whether you remove the disease or not is the problem. So I'm not as a Maslow's hammer. If all you have is a hammer, everything looks like a nail. So I'm arguing against institutional NSCT protocol, giving NSCT to all ovarian cancer patients. The patient selection is the important thing here. It has to be triaged. You cannot blindly advocate. You cannot hide behind a medical oncologist for a suboptimal surgery. So we advocate proper imaging, including CECT scans and also diagnostic laparoscopy before committing for primary surgery or cytoreduction. So my take home is R0 is the goal. Trust shows a relative evidence, and PARP inhibitor therapy amplifies R0. It does not replace R0 resections or CC0. Triage has to be there. So primary surgery remains only way to offer highest survival ceiling to fit and select patients, and let's not mask the enemy before we remove it. Thank you.